Bismillahirrahmanirrahim. Assalamu alaikum and good evening, ladies and gentlemen. I am Dr. Shan-e-Rauf and I am the moderator for this session. On behalf of HAEMCON2021, I welcome you all to this session. In this session, first of all, we will have a talk from Professor Dr. Ghulam Mufti, and it will be followed by the announcement of best oral and poster presentations. And then it will be followed by the concluding remarks by the chairperson HAEMCON 2021. Well, ladies and gentlemen, as you all know, Professor Dr. Ghulam Mufti, for whom I think words fail to describe his introduction, is a world-renowned global expert and a driving force for the research, diagnosis, and treatment of hematological malignancies. He is a pioneer who has radically transformed the way hematological malignancies were treated in the past. He has dedicated more than 35 years of his career to clinical work and research. He had been King's College London's head of Department of Hematological Medicine and had been non-executive director and clinical director of pathology at King's College Hospital, NHS Foundation Trust. He had been on board role for Viapath and Haematology Institute, Director, Academic Lead for King's Health Partners Academic Health Sciences Center. Recently, he retired from his administrative role, but still continuing his clinical activity. As head of hemato-oncology at King's College Hospital, his team, in collaboration with Institute of Liver Studies, carried out the first ever combined liver and bone marrow transplant at King's in 1985. Under his leadership, the hospital now has one of the largest bone marrow transplant programs in UK and performs over 200 transplants a year. Professor Dr. Mufti's specialist work in MDS, AML, and stem cell transplant has changed the lives of patients across the world. His achievements are countless, starting from being awarded as Order of British Empire for services to hematological medicine, identification of novel therapies, including gene and cell-based therapies, over 450 papers, first immune gene therapy program for leukemia, lifetime achievement award from Turkish government, and above all, training future generations, leaving his imprints on generations to come. Currently, he is chair and founder member UK MDS Forum, trustee of National Aplastic Anemia Trust, member strategic group for blood cancer, member European and International Bone Marrow Transplant Registries, founder member of MDS International Symposia, advisory role for Bone Marrow Transplant Program KSA, and countless UK, national, European, and international roles for which time is not permitting to narrate. Sir, please accept our apologies for not enumerating your achievements in full. To sum up, his services to hematological medicine is unrivaled, unparalleled, and has everlasting impact. We are fortunate that you are gracing this occasion, sir. Sir, the history of hematology indeed owes to your services and achievements. Sir, I would request you to please deliver your talk on the topic appraisal of chip. Sir, please.
Thank you very much for those kind words. This has been a very difficult year, as you know. Most of you will know it's been a cruel year because of COVID. And I remember when I came to Pakistan Society of Haematology meeting last time, I had the pleasure of being with Tariq Shafi, the late Tariq Shafi now, who was probably one of the best hematologists in terms of just excellence in the subject, but also as a human being and as an advocate and a symbol of Pakistan and Pakistani community, particularly in medicine and hematology in UK and beyond. God rest his soul. I will always remember him with great fondness for the amazing human being that he was. And I wish I had some of the characteristics that he had. And I wish I had the depth of love that he had for Pakistan at every step, at every breath. Whenever I met with him, he would kind of express his love for Pakistan. So God rest his soul. So what I think I will do is try and sketch out what the issues are and why they are becoming increasingly important for hematology as well as for other specialties. There is an emerging concept, which is that when we look at all stem cells, and it doesn't matter whether the stem cells are from any background and any animal, that there are differences that occur in stem cells of bone marrow, of stem cells of the gut, stem cells of the skin, that stem cells in early life are different to stem cells in later lives. So as we get older, there are certain changes that are taking place in these stem cells. So understanding these changes has become quite important because we know that in the practice of hematology, that as we get older, that these stem cells develop clonal changes inside them. In other words, they develop mutations of certain genes. Depicted here, if you like, are these various types of cells. And you can see that as we get older, these cells acquire different colors to the colors that we started here. In other words, that these cells are acquiring more and more mutations in them. And it may be that different mutations occur in different cells. And therefore, the clonal evolution of those cells is going to be different. So that is one of the main reasons why they are becoming important, because that emergence of clonal hematopoiesis due to aging has quite a lot of consequences for a human being, both in terms of longevity as well as in terms of the diseases that we suffer from. So why may this occur is becoming crucial in terms of understanding the biology of old age. Now, if we look at the last 10 years, a concept has emerged which is called inflammaging, which is that as we get older, our immune system and our body is more inflammatory than it is at a younger stage. So the question is, why does this inflammation occur? Number one. Number two, what is the effect of this inflammation in terms of generating, say, clonal hematopoiesis and its consequences? What we do know is that as we get older, there is an increase in certain cytokines. So if you look at TNF-alpha, if you look at interleukin-6, these are increased as we get older. And there are other changes as well that occur. For example, certain microRNAs change quite significantly, one of them being MER146, that has profound effects on a number of other inflammatory molecules. Importantly also is the fact that as we get older, we also get changes in our gut, so that the gut permeability increases. Gut permeability increases as a result of specific immunological changes that occur in the gut. Without going into details, there are changes that occur in, say, granzyme K-secreting cells. There are changes that occur in interleukin-17 secreting cells. The end result of those immunological changes in the gut is, if you like, for want of a better word, the gut becomes more porous, and therefore you get more of these inflammatory cytokines that are circulating from the gut. So there is an emergence of interest, therefore, in understanding how does the gut microbiome relate to clonal hematopoiesis. And can you change the clonal hematopoiesis if you change the microbiome of the gut? If you change the microbiome diversity in the gut, what effects will that have on the emergence of clonal hematopoiesis specifically, and generally on all the aspects of inflammation, aging, and therefore on autoimmune diseases of one sort or the other. So this is why this clonal hematopoiesis is kind of becoming an important area of investigation. Now, for us, hematologists, let's just concentrate on the key changes that occur in hematopoietic stem cells when we get older. So if you look at a young person, there is a balance between the number of myeloid cells and the number of lymphoid cells that come from multipotent progenitor as well as from the long-term and grafting hematopoietic stem cells. In other words, in a younger person, you have balanced production of myeloid cells and balanced production of lymphoid cells. Now, this is important because when you have a balanced lymphoid cell population, that means that you will have a balanced innate immunity as well as an adaptive immunity. So the two are going to be balanced. Now, as we get older, there are a number of changes that take place in the stem cells. One of these is reactive oxygen species generation due to inflammation aging, and that leads to changes that occur in the polarity of the stem cells. In other words, how they are sitting in the microenvironment, the relationship between a hematopoietic stem cell and its microenvironment, and also what changes are occurring in the epigenome of these cells. As you know, that the DNA is wound around an octamer of histones. So you have octamer of histones depicted here. So there are 2 H3s, 2 H4s, and 2 each of H2A and H2B, and they are wound around. The DNA is wound around those. It's important to understand that because these histones, they are key in terms of whether these histones, they are amino acids, if you like, and these amino acids are predominantly positively charged amino acids, and the two predominant positively charged amino acids in the histones are lysine and arginine. And these lysines and arginines depicted here, they can get acetylated or they can get methylated. And when they get acetylated or methylated, there are changes that take place in the DNA in terms of whether it is accessible to transcription factors and therefore whether transcription of a particular gene is taking place or not. So for some trimethylated lysines, for example, you get a shutdown of the expression. For others, you get an expression of de-repression of expression, so therefore you get expression. So this epigenetic drift takes place, and I'll show you on the next slide what change takes place in that. As a result of all these, the effect is that in an older person, the older hematopoietic stem cells get a myeloid bias. They become more myeloid. So we produce more myeloid cells than we produce lymphoid cells. Therefore, our immune system switches. One, because of the types of myeloid cells that we get, say changes that occur in the monocytes and macrophages. And secondly, because of the changes that occur in the lymphoid cells, predominantly change occurring such that we don't now mount a good adaptive immunity response. We have predominantly an innate immunity response. So the question then is, what are the genetic changes that take place that lead to this myeloid drift? And incidentally, this myeloid drift occurs in almost all the mammalian populations wherever hematopoiesis has been studied. So appears to be quite important and appears to be quite uniform. So now, if you now look at the mutations that occur, so if you kind of, the correct assumption probably is that we have about 20,000 hematopoietic stem cells when we are born, and those are the cells that give rise to 7 to 8 billion cells in a 24-hour period in a human being throughout our life. But every time a stem cell divides, it acquires a mutation. And these mutations are mostly in the non-coding regions of the genome. So therefore, they have less of an effect, although those are becoming important now. But every decade, we will acquire a mutation in an exon. And when we have a mutation in the exon, then if it is a bad mutation, that cell will be killed because it's incompatible with existence. Or if it's a mutation that a cell can tolerate, then you will get the clonal expansion of those cells. So that's, if you like, number one. Number two is, if you now look at a more detailed analysis of the older stem cell versus a younger stem cell, older stem cells have more chromatin condensation. In other words, the ratio between euchromatin and heterochromatin is different in that there is more of heterochromatin than there is of euchromatin. In other words, more genes are shut down rather than them being expressed. Another key change that occurs in the older hematopoietic stem cells is that they are getting more and more dependent upon glycolytic pathway for generation of ATP and energy. And also, functionally, if you now take the stem cells from an older person and then you put them into mice, either immunocompetent or incompetent mice, and then you do a secondary transplant from one mouse to another mouse using older hematopoietic stem cells, you will find that they have a reduced secondary transplant capability. In other words, they have reduced engraftability because they cannot go on producing cells from one generation of mice to another generation of mice. So that kind of is important as well. Now, there are a number of genes that change also between young cells and old cells, and those cells that have the mutation as well as those that don't. And importantly, what happens is that if you now look at certain genes and look at the epigenetic signature, which is what I was telling you before, so if you look at the histone 3 and lysine, K stands for lysine amino acid, number 27, if this lysine is trimethylated, then you get a suppression of expression. So if you look at here, there is a suppression of expression in some cells. On the other hand, if you have a lysine 4 that is trimethylated, you get an increase in the expression. So if you look at these cells, you find in the lymphoid cells, there is a downregulation. In the myeloid cells, there's an upregulation in an older person who, for example, has CHIP. In relation to what you see at the bottom, the ratio between H3K27 trimethylation and H3K4 trimethylation. So H3K4 trimethylation is an epigenetic mark for expression of a gene. H3K27 trimethylation is an epigenetic mark for suppression of gene expression. So those are kind of now being used as tools, amongst other things, to try and see what genes are and what genes aren't being expressed by older cells as opposed to younger cells. This whole area came into focus when people started looking at thousands of patients as well as normal people, and noted that as we get older, many of us develop clonal hematopoiesis. That this clonal hematopoiesis is rare before the age of 40. And interestingly, when you look at the mutations, and I'll talk about them in a bit of detail, that these mutations are more common. Change that occurs is a C to T transition. So cytosine to thymine transition, which is usually deamination, and that is due to reactive oxygen species in many instances. And this has been termed as the aging signature. So when you have a mutation, and mutation has arisen because there has been a C to T transition in a particular gene, it's kind of more or less referred to as aging signature. And majority of these mutations are single mutations. And these mutations, if you look at the types of mutations that occur, they occur in more than 60% of cases in 3 genes: DNMT3A, TET2, and ASXL1. This is now called DTA signature. So DTA signature is DNMT3A mutation, so that affects the methylation of the genome. TET2 also affects the methylation of the genome, and ASXL1 does the same thing. So predominantly, changes are taking place in the methylation of either DNA or of the histone tails, as I described before. So here is a spectrum of mutations that occurs as we get older. So you will get DNMT3A, TET2, ASXL1, and interestingly, TP53, which I'll talk about in a minute, and JAK2 and spliceosome mutations such as SF3B1 and SRSF2. So these are spliceosome mutations, and another P53 pathway mutation like PPMID and BCOR and BCOR-L1. So a limited number of genes are becoming mutated. The question is, how many of us do get these mutations? Now, when you look at the techniques that are used to see clonal hematopoiesis, the mutation spectrum differs a bit on whether you have done a targeted sequencing or a whole exome sequencing or a whole genome sequencing. So as you can see here, that if you look at the variant allele frequency as well as the density of mutations, when you do whole genome sequencing, you will obviously find more mutations. But when you do a targeted sequencing, because the reads are deeper, so you will pick up only those genes that you have targeted for, but you will pick them up at a very low variable allele frequency as well. So it depends upon the technique that you are using. Roughly, though, 10% of us over the age of 70 will have these mutations. And as time goes on, many of us will then see the consequences of these mutations. Now, here is a spectrum of these mutations. So DNMT3A, roughly half the people. TET2 mutations, ASXL1. So this is the DTA signature in clonal hematopoiesis. Clonal hematopoiesis at the present moment is defined when the clone size is over 2%. In other words, 4% of the cells will have the mutation. So that's the definition of clonal hematopoiesis of indeterminate potential, is when you have a variable allele frequency of over 2%. Now, you can see here, spliceosome mutations occur in about 6%, JAK2 about 3%, TP53, and then there are other mutations as well that occur. Again, this is kind of quite important when you look at these spliceosome mutations in detail, because not all mutations have the same significance. Some mutations will predispose to development of MDS and acute myeloid leukemia at an earlier stage, whereas other mutations will not predispose to hematological malignancies, but will predispose to a shorter overall survival. So anybody who has got clonal hematopoiesis, irrespective of the gene, if you look at those people who have clonal hematopoiesis versus those who don't, people with clonal hematopoiesis live significantly shorter than people who do not have clonal hematopoiesis, irrespective of whether or not they develop MDS or acute myeloid leukemia, indicating, therefore, that this clonal hematopoiesis has other effects. So why are people dying when they have clonal hematopoiesis? They are dying because, let me just go to this. They are dying because of cardiovascular disease, because of strokes, because of type 2 diabetes, also because of deep venous thrombosis, and now increasing evidence that you can get chronic obstructive pulmonary disease, and again, changes that occur in the brain as well. So, but majority of the patients are dying as a result of cardiovascular disease, diabetes, or strokes. So the question then is, why is this the case? So can you create a model whereby you can show that if you have a mutation in a particular gene, that leads to changes that occur in the endothelial cells, particularly endothelial cells of the heart, so that you get early deaths. So what this group in Boston did is that they took mice that had deleted genes such that they become predisposed to atherosclerosis. So they deleted apolipoprotein genes in them, and therefore these became more prone to atherosclerosis and hyperlipidemia. And in these, then, they either knocked out the TET2 gene or they kept the TET2 gene in there. TET2 is one of the genes, as I mentioned, which is quite common in clonal hematopoiesis. What they showed is that when you have a TET2 mutated gene, that you get an expansion of the macrophages, you get an increase of macrophages excreting pro-inflammatory cytokines such as interleukin-1, beta, and also activation of the inflammasome pathways. So one of the important inflammasome pathways is NLRP3 pathway that needs to caspase activation and IL-1 and IL-18 secretion. And when you inhibit NLRP3 pathway, then you get a reduction in this inflammation. And when you look at loss of TET2 function, you get increase in this NLRP pathway causing inflammation in the endothelium. And if you then look at the aorta as well as cardiovascular system, you get inflammation, aortic loops, atherosclerosis development as a result of the TET2 loss of function. So it appears that aging signature, at least due to TET2 mutations, is as a result of TET2 causing inflammation, particularly inflammation of the monocyte macrophage series because of the myeloid bias that occurs in TET2 knockouts in this particular experimental system. And interestingly now, people are finding the same thing in human cells as well. So there is beginning to be a theoretical explanation for it. It's not going to be remaining theoretical for too long because you can imagine that people are now beginning to think about, well, there are lots of drugs now that can interfere with this activation of the inflammatory pathway, NLRP3 pathway, both in terms of anti-IL-1, anti-IL-18, as well as small molecules that specifically inhibit the NLRP3 pathway. So this is important in terms of future treatment in these cases, as is indicated here, that you can have IL-1 neutralizing antibodies, a small molecule NLRP3 inhibitor, as well as hypomethylating agents. Not only that, then the next question is, if reactive oxygen species is a hallmark of inflammatory aging because it is generated through various inflammatory pathways, then can you then look at what are the key proteins that are taking part in the acquisition of that reactive oxygen species so that doesn't persist in the cells, particularly in the dividing cells, and lead to either cell death or tumorigenesis. Without going into details, that many of the enzymes that are involved in mopping up reactive oxygen species, those are known, and those functions and expressions and deep repressions are known. And this is kind of becoming another important area whereby you can now influence, at least in the experimental settings, the mopping up capacity of the cells in terms of reactive oxygen species, because reactive oxygen species is quite important in terms of this thiol oxidation and what I told you before, C to T transitions in the nucleotides in the DNA. So that may find a practical utility as well. For the practicing hematologist, what does it mean? You take a sample from a patient and you find that you do a myeloid gene panel. You find that there is clonal hematopoiesis because the clone size is more than 2%, and it involves any of the genes that I have described. Mostly there are about 20 genes, but in fairness, top 90% of the genes, top 90% are in the 6 genes, DNMT3A, TET2, ASXL1, then the spliceosome pathway genes and P53 and PPMID. So you have detected a mutation. What does it mean? So it's somebody who has got clonal hematopoiesis of indeterminate potential. Their blood counts may be normal, but the only thing they have is the clonal hematopoiesis. There's another person who has got clonal hematopoiesis, but also is cytopenic, as is shown here, but have less than 5% blast. So this condition is now called CCUS. And then there will be another person who's got the full house, who's got clonality, who's got bone marrow dysplasia, who has cytopenias. So that will be now in the proper MDS category. You could argue that these patients are also really examples of the low-risk MDS. So the question is, can you stop progression from CHIP to CCUS? Indeed, is there a progression from CHIP to CCUS? And if there is, how often does it occur? And similarly, is there a progression from CCUS to low-risk MDS? How frequently does it occur? And how can you disrupt it in real life? And that's an area that has been given impetus now by drugs such as oral 5-azacitidine, the role of vitamin C, for example, because vitamin C has been shown to increase the expression of TET2. So vitamin C trials are ongoing, particularly in people who have TET2 mutations, precisely to try and disrupt this transition from CHIP to CCUS to lower risk MDS. So this is for the practicing hematologist. The other question that occurs is that if you have a mutation, does it matter which mutation it is in terms of telling the patient, you know what, you are likely to develop a hematological malignancy or not? So if you now look at studies that have been done, and there have been many studies that have been done, and to cut a very long story short, that when you have 2 mutations instead of 1, there is more likelihood of a myeloid neoplasm emerging. So if somebody has a ASXL1 as well as a DNMT3A, he or she is more likely to develop MDS or AML than a person who has only 1 mutation. Secondly, if the variable allele frequency is more than 10%, so in other words, the clone load is higher, again, those patients are more likely to develop MDS and AML. Interestingly also, when you have spliceosome mutations, whether those spliceosome mutations are SF3B1, SRSF2, or U2AF, these are the 3 common spliceosome mutations. These are associated with a higher risk of transformation to MDS and AML. So these patients who have these characteristics, as well as those who have co-mutations, so you have TET2, DNMT3A, ASXL1. TET2 on its own does not correlate with increased transformation to AML, nor do any of these. Interesting thing is, when you take, when you knock out TET2 and DNMT3A in mice, the only change that you get is an increase in the stem cell numbers in the marrow. You do not get any other specific changes, even in a homozygous state. So for the practicing clinician, it's kind of important to know 2 mutations, particularly mutations of the spliceosome genes, and a WAF of more than 10%. Now, just one particular point about spliceosome mutations, which is that spliceosome mutations have a hotspot of mutations. So SF3B1 predominantly will occur at position 700. K700E is the commonest mutation. Similarly, SRSF2 involves a proline at position 95. There are other positions that can be affected as well. And it is unclear whether those other positions, other than the hotspots, are also associated with similar increased risk of transformation to MDS or AML. But for the classical ones, which is in position 700 for SF3B1, position 95, and S24 for U2AF, those are associated with higher risk of transformation. So that's kind of important to know, because you do find about 5 to 10% of people, say with SF3B1 mutation, will have a mutation at another site like 666 or 662 or 622. Those are the common, less common sites, but they do occur. And the interesting thing also is that you must know that when SF3B1 mutation occurs at position 700, you don't get another S spliceosome mutation. You get, particularly, you don't get SRSF2 P95. This is what's called epistasis, because cell cannot tolerate both mutations, particularly if they're in both alleles. So you always find that with classical SF3B1 and SRSF2, you get one or the other of the mutations. Now, mutations don't occur just because of age as well. They occur in a variety of hematological disorders, get a clonal hematopoiesis. Now, this frightening slide is our work on aplastic anemia, massive EBMT trial, where we are looking at immunology as well as clonal hematopoiesis. The interesting thing is that we described first that in aplastic anemia, you get clonal hematopoiesis. Now, in this large EBMT race trial, where we are doing the science behind it, what you can see is there are a lot of patients with lots of mutations, with lots of allele burdens that vary from very low level allele burdens to as high as very high levels of allele burden. And in many instances, they remain like that. In some instances, they go down. In other instances, they go up. And this is something which we are following. So clonal hematopoiesis in aplastic anemia, after you have given the treatment, whether with immunosuppressive therapy, etc., is another important area of understanding what is the risk of developing MDS AML. You will know that about 15% of patients with aplastic anemia after about 10 years will develop MDS or AML. So the reason why we are doing clonality in these patients is to ascertain whether that risk is there. And in our hands, if you have certain mutations, you have a higher risk of transformation to MDS and AML in aplastic anemia. Similarly, if you now look at clonal hematopoiesis that occurs in other conditions like bone marrow failure syndromes, say Liframini, where there is P53 mutation, then there is a risk of getting clonal hematopoiesis and MDS, or SBDS, Schwachman-Diamond syndrome. Again, due to ribosomal stress, they have P53 mutations. Again, there is a higher risk of development of MDS, clonal hematopoiesis than MDS and AML. And similarly, if you now look at breast cancer patients, those patients who have been given particularly platinum, that they can develop P53 mutations and then develop MDS and acute myeloid leukemia. Now, this is a very, very interesting field, because you would have thought if somebody is heterozygous for Liframini, so 50% of their cells, therefore, have a P53 mutation, then they should develop leukemia and cancers at an astronomically high level, but they don't. Only 5% of these patients will develop MDS and AML. Similarly, in Schwachman-Diamond, because they have a constant ribosomal insufficiency and therefore ribosomal stress, and they have high incidence of P53 mutations as a result, they get clonal hematopoiesis, but they don't always get MDS and AML. True, there is higher incidence of it, but not always. Similarly, if you look at breast cancer patients, there is this increasing interest in breast cancer. Do we have patients who develop therapy-related MDS in breast cancer? Do we have small numbers of cells in them that have clonal hematopoiesis due to, say, p53 mutation? Then you give them a genotoxic stress, which is due to chemotherapy. Then they will select that clone that has got the p53 mutation. And it is that original clone which then expands and gives rise to MDS. The other thing is that that indicates that one stress alone is not enough to go from one state to a frankly malignant state. You require a number of stresses that occur in a cell in a sequential manner for there to be a change from a relatively benign but abnormal state to a frankly malignant state. And again, this is something that if time permits, I can go into details of. Now, I won't bore you with this, but this is kind of the slide that kind of shows with each treatment, with, say, platinum-containing compounds, there is an increase in the number of cells that are involving the p53 pathway, and PPMID being one of the genes. So more DNA damage there is, the more the likelihood of clonal hematopoiesis. One of the interesting things that I would like to point out is that if you now look at sickle cell disease, more and more of us are doing transplants in sickle cell disease. And a few weeks ago, you would have seen gene correction of sickle cell disease using CRISPR-Cas as well as a lentiviral vector. There is a worry that sickle cell disease patients, there have been a number of studies in allograft situations where, say in one study, 4 out of 76 patients who had received allogeneic transplant developed acute myeloid leukemia. So, and also the incidence of clonal hematopoiesis in patients with sickle cell disease is 2.5 times higher than it is in a Caucasian population. Now, there are a number of reasons for that. But again, if time permits, I'll go into details of those. So that's one of the worries also with the gene-corrected cells, because you're creating, particularly with CRISPR-Cas, that every time you create a break in the DNA, which is a double-strand break, that will activate the p53 pathway and therefore will predispose a cell to genomic instability if it isn't corrected appropriately. So, so this is kind of, this is my final slide. I'm coming to the end now. I apologize for going on. One of the things that we have become interested in, and which is what I'm doing in my old age now, is I became interested in what is the correlation between mutations that occur, whether they are age-related mutations or not, and the immune system. So does the immune system just, is it an innocent bystander and looks at these mutations and nothing happens? Or is an immune system an active participant in either identifying these mutations and getting rid of these cells? Or is there any way that you can stimulate the immune system to recognize the abnormal epitopes that appear as a result of the mutations that occur in specific proteins in the genes that, for example, are mutated in MDS, which are listed here? So what we started doing was first to look at, is there a difference in survival between those patients who have a mutation, all CHIP patients included, versus those who don't have a mutation. So, and then we looked at when you have got a mutation of a particular gene, then is the protein going to be presented in the HLA? So is there a neoantigen that is generated? And is that neoantigen then presented in the right way in the HLA? And then is there an effective immune response against it? In other words, is there a T cell response which is productive, recognizes the abnormal antigen and gets rid of it? One part of it was first to use these, there are all sorts of databases that are available. So if you have a mutation at a particular site, you can put it into that database in a particular HLA type. Then you can see whether this gene is, whether that abnormal protein is going to be presented or not. In other words, is it a neoantigen or not? Interesting thing was the differences between survival between those who are neoantigen positive and those who are neoantigen negative. Now, this has been expanded to thousands of patients at the present moment. So this is kind of my final slide, is the kind of, some of you might have seen this slide, is what we are doing at the present moment. So we are taking a large number of patients and people who are having hip replacements. Roughly, we are taking about 1,500 patients per year who have hip replacements. And then we are looking at their history of cancers, their history of autoimmune disease, and looking at their bone marrow progenitors and doing multi-omics on the cells in the marrow, cells in the blood. And then once we have done that, we then do on the immune system side, we do site-off so as to recognize the full plethora of the changes that occur in the immune profiling, and then to link it with the clinical impact that it will have. And with samples being taken from these patients at regular intervals to see how the clone expands, what the immunological response is to the clone, and also which genes matter. The other thing that we have added to it is the microbiome for reasons that I indicated earlier. And also there is a study going on with the cardiologist, which is kind of looking at this markers of inflammation in both the coronary vessels as well as in the blood. There is another study that Lynn Queck is leading on, again on clonal hematopoiesis in breast cancer patients for the reasons that I described. And we have now just started doing the sickle cell disease study. And that's fascinating. There are papers in Science, etc., that have looked at some of the key genes that regulate certain ancestral polymorphisms that exist in certain populations, which lead to changes in the expression of genes of one sort or the other. And that's become important in terms of immunological memory and this huge interest in this COVID era as to, for example, why in Asia is there a lower incidence of complications as opposed to the Western population? Is it all due to age, or are there other racial factors which are genetic that are in part responsible for it? But that's kind of as an aside because of the GWAS studies that will be done on this study. So I'll stop here and I'll answer any questions.
Thank you so much, sir, for such enlightened talk on the topic. And we are very thankful to you, sir, for sparing your precious time for this, sir, for this scientific session, sir. Sir, thank you so much.
Thank you.
Ladies and gentlemen, now we will have the announcement of best presentations, best oral presentation, best poster presentations, and I would request my panelist to announce the presentation award presentation. Sir, please.
Thank you, Dr. Shan-e-Rauf. Now, I am privileged that I, along with the Professor Lubna Zafar and Professor Xia Jun, we listen to and scrutinize all the paper. Few point, the one thing, important thing is all the studies. They highlighted very pertinent point, topic encompass the topic from the bench to the bedside, well planned, well executed, and most of the study data presented in an excellent manner. And I studied the statistical method and the evaluation were required. They all were applied in an adequate manner. And then few studies, one from the two from the China and few studies from the NUMS and the KRL, where there is Chinese collaboration. the main thing is that all these studies, they have a very futuristic magnitude, and hopefully they will go a long way in the patient management. And then apparently all these researches tend to have a great value, inshallah, in the hematology practice, and maybe have a lot of benefit for the patient. Now, after this, we will first announce the positions for the trainees position with the consensus from the Professor Lubna Zafar as well as the Professor Xia Jun. The first one is from the Jian Zhou from BGI-Shenzhen, China. He's an excellent work. The topic was for comprehensive pre-implantation genetic testing by massively parallel sequencing. The second position is it goes to Dr. Gulrukh Suhail from Hayatabad Medical Complex, Peshawar. The topic was the molecular characterization and frequencies of different genetic ameliorating factors in transfusion-dependent thalassemia patient. The third, it goes to the Dr. Noor Shamim from Armed Forces Bone Marrow Transplant Center. The topic was the outcome of autologous stem cell transplantation in lymphomas. Then one position for the paramedics and lab technologies, that is with the Dr. Zainab Akram from Bone Marrow Transplantation Center. The topic of her work was the telomere length measurement. Then one position for the nurses, it is with the Najia Gul from the Bone Marrow Transplantation Center. The topic was complications associated with central venous catheterization. Then the e-poster. In e-poster, the first position, it goes to the Nabila Rafiq, Dr. Nabila Rafiq from Armed Forces Bone Marrow Transplantation Center. The topic was long-term outcome of beta thalassemia major patient post-allogenic transplantation. The second position, that is to Dr. Khatida Ijaz from Indus Hospital, Karachi. The topic of her presentation was distribution of subtypes and immunophenotyping characterizations of pediatric acute leukemias. The third position, it goes to two doctors, two candidates. Number one is the doctor. So the third position goes to two doctor. One is the Dr. Sumaira Sheikh from Indus Hospital, Karachi. The topic of her poster was relapsed childhood B lymphoblastic leukemia and its association with prognostic factor. The other one, third position, goes to the Dr. Numan Rana from AFIP, Rawalpindi. Topic was assessment of response of induction chemotherapy in childhood acute lymphoblastic leukemia. Thank you, Dr. Shan-e-Rauf.
Thank you so much, sir.
Okay, thanks. I'm honored to have the opportunity to introduce my work here. I work for BGI-Shenzhen for a long period of time. Working at BGI, I was mainly engaged in the development of a new method for pre-implantation genetic testing. So today I will introduce our latest work on PGT. PGT, formerly known as PD and PGS, is a test performed to analyze the DNA from embryos for HLA typing or for determining genetic abnormalities, including the PGT-A for detecting the Aneuploidy in embryos, PGT-M for detecting the monogenic disorder like thalassemia and hemophilia, and the PGT-SR for detecting the chromosome structural rearrangement in embryos. The method for PGT has been developing for more than 30 years. From fish, we know that STFR-based method and the PCR-based method to array-based method, such as array CGH, slip array. And then the method moved to evolved to MPS-based method. So BGI is one of the first situation to use the MPS for PGT testing. From 2012, BGI tried to use NGS to detect the chromosome abnormalities in embryos. This study first provides the evaluation of the clinical outcomes of NGS-based PGT-A method and shows the reliability. And also, we want to apply the NGS to detection of PGT-M. In that time, about 2040, the high depth whole genome sequencing was very expensive. So we developed a method that combined target sequencing and target haplotyping to identify the mutation in IVF embryos. We performed the Sanger sequencing combined with the target haplotyping to evaluate the feasibility of this new method. A family signal specific haplotype analyzed based on SNP genotyping of the parents and the parental grandmother. According to the SNP genotypings of embryos, we can infer that embryo inherited haplotype 1 of the father was abnormal. Haplotype 2 of the father is abnormal. According to this method, we detect the haplotype of 7 embryos from PKD2 carrier family. The result was 100% accurate and was consistent with Sanger sequencing. And PT is PT of single gene disorder combined with HLA matching can be as a tool to select unaffected embryos of an HLA tissue type compatible with an existing affected child. We did a retrospective study in a beta thalassemia family. We developed a strategy to obtain the full embryonic genome for a beta thalassemia carrier couple to have a healthy second baby. The transferred embryo was collected for more than 30 depths WGS. We diagnosed these transferred embryos as beta thalassemia lective. The genotype of HLA gene has been used before transplantation. For the family, the umbilical cord blood stem cell of the transferred embryos could be used to treat the preborn sisters' thalassemia. We selected the heterozygous genotype of all the HLA gene in NGS data to predict the transmission haplotypes of each embryo. According to the predictor transmission, the haplotypes of the transferred embryo was consistent with the preborn sister. Thus, we determined their HLA types were matched. Until now, high depth WGS is also a little expensive. So, several long depth MPS-based methods, including PGT-M and PGT-SR, have been developed. But this method, they also an additional family member, such as a sibling or a proband, is required for PT and haplotyping. So we developed a WGS-based method use medium depth WGS data for comprehensive PGT, include PGT-A, PGT-M, and PGT-SR. It can detect embryonic balanced translocation and to do parent-only genome-wide PGT haplotyping. This is the workflow. We do the whole genome amplification for embryo biopsies and prepare the libraries, the sequencing them with MGI sequencer. We get more than 17 depth WGS data, and this data will be used to detect the mutation of embryos. WGS-based PT can detect the mutation directly and do haplotyping and chromosome profiling by the sequencing of whole genome amplified blast-mir or blast-sister biopsy. It able to enable the parent-only PGT-M or PGT-M with the proband PT structural rearrangements and PT for Aneuploidy analysis. We use Qpcr mapping and macro-seq with PCR-seq to for the validation. SNPs we used for haploanalysis in informative SNPs in the gene and upstream and the downstream regions of the target gene were analyzed. Figure on right shows the overview of PGT-M haplotyping with a proband and parent-only haplotyping without additional family members. The left shows the overview of WGS for monogenic disorders haplotyping with a proband. The right is no proband, just the parent only with a reference embryo. We defined the embryo with the heterozygous pathogenic mutation as the reference embryo. For the parent-only haplotyping, we performed the haplotyping based on the number of the SNPs detected for each embryo. M1 for and F1 for defined as the maternal haplotype 1 and the paternal haplotype 1. M2 and F2 were defined as the maternal haplotype 2 and the paternal haplotype 2. And in this study, 10 families was included to assay WGS-based PGT. Along this family, 8 showed genetic risk of monogenetic disease, including autosomal recessive genetic disease, autosomal dominant genetic disease, and sex-associated genetic disease. And family 2 and family 1 and family 2 were used for method evaluation. The remaining 2 families showed parental balanced translocation. We use them to evaluate the PGT-SR performance. Family 1 and family 2 with an average of 17 depth damage data. According to the result of direct detection of pathogenic mutation, 4 embryos of family 1 and 4 embryos of family 2 showed heterozygous mutation. We assessed the graduate depths of embryo data and found that 4 depths of embryo sequencing data enabled to credible testing of mutation. We further evaluate the result of WGS haplotyping of the target gene with and without proband using a gradient depth of embryo or family member sequencing data, and found that with more than 4 depths embryo data and 10 depths family member data, the haplotype of the target gene could be determined both with and without a proband. We conclude that the 4 depths of the embryo data and the 10 depths of the parent data were required for the reliable PGT-M direct genotyping and haplotyping. And also we evaluate the genome-wide performance of the WGS for the blast-mir and the blast sisters. We compared the depth and the GC content and the DNA respectively of the genes. We found that the GC content influenced the sequencing depths. The peak of the sequencing depths coincident with 41% of the gene content, and the high or low the GC content, the low was the sequencing depth and the average and the coverage. The depth and the coverage distribution of the genes in each embryo are different. Blast sisters are better than blast mirs, We also evaluate the allele dropout for WJS and the carrier mapping of the embryos. The mean allele for carrier mapping was higher than that for WJS, and the mean allele of the blast mirror was higher than that of the blast sisters. We further evaluate the haplotype prediction on a genome-wide scale for both the carrier mapping and the WJS data on family 2 and family 1. Each evaluate 2 embryos. The genome haplotype obtained by WJS was similar, very similar to that obtained by carrier mapping, except for some small segment. Most of them were in telomeres, and some difference were in recombination sites or centromeres. We can see it in its figure. And for the 8 PGT-M families, WJS haplotyping of each target pathogenic genes with a per band was performed for 40 embryos. And haplotype results were obtained for 100%. Carrier mapping verified all the embryos, and 100% concordance between the WJS and the carrier mapping. WJS enabled direct genotyping of the pathogenic mutation for PGT-M. The embryonic pathogenic mutation could be directly tested for 7 out of 8 families with 33 embryos. But note family 3, because the mutation of the DMD could not be distinguished among the noises. ADO was observed for 3 embryos. All of the result of WJ parent only PGT-M haplotyping were 100 concordant with those WJS haplotyping with a proband and were validated by carrier mapping. And beyond PGT-M, we performed the PGT-A according to a previously method we established in 2030. PGT-A was performed for all the 40 embryos from the 8 families. WJS detected 23 embryos with a normal karyotype. 70 was with Aneuploidy or CMVs. The slip array result verified all the embryos and showed 100 concordance. The figures showed the Aneuploidy result from the embryos with copy number variation. Then we performed the PGT-SR, uses the embryo with unbalanced translocation as the reference to distinguish between balanced translocation carrier and normal embryos. The PGT-A CMV breakpoint of the unbalanced reference embryo was identified as the translocation breakpoint. We performed the haplotyping for each embryo using the informative SNPs in 500 kilobits upstream and 500 kilobits downstream of the breakpoint region to determine whether the embryo was a balanced translocation carrier or a normal embryo. PGT-SR by WJS were performed for family 8 and family 9 with 30 embryos. The father of the family 8 was carried of balanced translocation between chromosome 5 and chromosome 50. And according to the result, doctor chose some embryos to implantation, and according to among the 8 PGT-M families, 5 families achieved healthy birth implantation for family 1 and families Family 1 and Family 3 are failed, no embryos available for transfer for embryo Family 10. Family 8 and Family 9 of PT-SR achieved the healthy birth embryo transfer. So make a summary, in this study, we developed WGS-based method with 10 depths of family member and 4 depths of embryo sequencing data for comprehensive PT. This method offered a PT-M approach for haplotyping without the requirement for additional family members. WGS best, but there are some limitations. The reference embryos was not available owing to failed direct genotyping or an insufficient number of the embryo in some cases. And the GC content possibly influenced the sequencing depth. It may not be possible to detect the embryonic pathogenic mutations in region with too high or too low GC content. But this WGS-based comprehensive PT method also provides an improvement complement to the current PT method. And last, I want to say thanks the partners who participated in our study. Okay, thanks.
Thank you so much, Dr. Junzia, for your talk. The second position was awarded to Dr. Gulrukh Sohail from Hyderabad Medical Complex, and her topic is molecular characterization and frequencies of different genetic ameliorating factors in transfusion-dependent thalassemia patients from District Peshawar. Over to you, Doctor.
Assalamu alaikum. I'm Dr. Gulrukh Sohail. I'm going to present my research article, which is based on my MPhil thesis, title of which is Molecular Characterization and Frequencies of Different Genetic Ameliorating Factors in Transfusion-Dependent Thalassemia Patients from District Peshawar. Thalassemia syndromes are the most common genetic disorders worldwide, which causes significant mortality and morbidity. In Pakistan, thalassemia is an ongoing public health issue as well. An estimated 5 to 7% of our population is affected from beta thalassemia. On the other hand, the overall frequency of alpha thalassemia in our Pakistani population is 8.3%. Thalassemia is a heterogeneous group of genetic disorder, and a number of environmental and genetic ameliorating factors can modify the severity of the disease. The genetic factors which influences the severity of beta thalassemia includes the type of the beta thalassemia mutation, like the inheritance of the milder type of the beta mutation, co-inheritance of the alpha thalassemia along with the beta thalassemia, and presence of different polymorphisms which are associated with the increased production of hemoglobin F. All these ameliorating factors reduces the alpha-beta chain imbalance, and as a consequence reduces the ineffective hematopoiesis or erythropoiesis. HbF level is mainly regulated by 3 quantitative trait loci, which includes Xamin1 polymorphism or C to T variation at position 158 on chromosome 11, HBS1L MYB intergenic region on chromosome 6, and BCL11A polymorphism on chromosome 2. Together, these 3 quantitative trait loci are responsible for the variance of the level of the HbF in patients with beta thalassemia or sickle cell disease or in the healthy individuals. In KP, a large number of the thalassemia patients exist, and here the local setup is such that patients are mostly diagnosed on the basis of their HB electrophoresis without going for their genetic or molecular analysis. Hence, there's a likelihood to misdiagnose thalassemia intermedia and the thalassemia major patients. And very little work has been done on the local population of the district Peshawar regarding their molecular or genetic studies. So in my study, we screened the local patients of the district Peshawar for different genetic ameliorating factors in order to ascertain the severity of the genetic change. Hence, the objective was to assess the diagnosis of multi-transfused thalassemia syndrome patients and to determine the frequency of different genetic ameliorating factors among the study patients. Study design was cross-sectional descriptive study. Study settings include Institute of Basic Medical Sciences, KMU Peshawar, Fatmid Foundation and Blood Services Peshawar, and National Institute of Blood Disease and Bone Marrow Transplantation, Karachi. We enrolled 54 transfusion-dependent thalassemia patients from the Fatmid Foundation. Inclusion criteria was, we took 54 registered patients of the Fatmid Foundation who possessed a valid and a verified HB electrophoresis report. And mainly the study was conducted on the pediatric age group, up to 15 years of age. Patient with any active metabolic or systemic disease was excluded because that can influence the severity of the disease, and patients with thalassemia trait were also excluded. That was beyond the scope of our study. After the sample selection, a comprehensive questionnaire which encompassing the demographic and clinical data was filled out for each patient. Blood sample was collected and DNA was extracted. In the results, the mutations, known beta mutations were screened in the study population. These mutations include IVS15, Preimplantation 89, Preimplantation 41, 42, IVS11, deletion 619, CD15, CD5, CD30, Preimplantation 16, CAP+1. These beta mutations cover almost 98% of the beta thalassemia mutations in Pakistan. Study patients were screened for the common single alpha gene deletions, that is 3.7 kb gene deletion and the alpha deletion 4.2. Patients were also screened for the XMN1 polymorphism and RFLP by RFLP PCR, and for BCL11 polymorphism, allele specific PCR was performed. In the results, the 54 patients which were analyzed for the common alpha and beta mutations and deletions, beta mutations were identified in all 54 cases. The most common beta mutations which was identified in the study patients was Preimplantation 89, homozygous Preimplantation 89. Then homozygous IVS15 was observed in 9%, and then heterozygous IVS15 and Preimplantation 89 was observed in the 6%. 11 patients out of the 54 were found to have coexisting alpha thalassemia gene deletion, that is the alpha 3.7 gene deletion. Alpha 4.2 was detected in none of the patient. Here this pie chart showing the frequency of the alpha mutations. Out of the all 54, 11 patients were showing the alpha coexisting alpha mutation along with the beta. Out of the 54 patients, 2 patients had examen1 polymorphism. That was heterozygous examen1 polymorphism. None of the patients showed homozygous examen1 polymorphisms, and 38 patients out of 54 had BCL11A. Here you can see that 2 patients out of 54 were showing the heterozygous examen1 polymorphism, and 52 were negative for it. Out of 54, 38 showed BCL11A polymorphism, and in 16 patients, BCL11A was not detected. Only 13 patients out of 54 were found to have isolated beta globin gene mutations. As we discussed earlier, that ameliorating factors like the inheritance of the milder type of beta gene mutation, or the co-inheritance of the alpha along with the beta, and the presence of the different polymorphisms which are responsible for the increased HbF production, all these lessens the severity of the beta thalassemia disease. So in our study, we found that these ameliorating factors were found in about 85% of my study patients. Only 15% of the patients were without any ameliorating factor. And any patient which has more than one ameliorating factor is likely to have thalassemia intermedia. Presence of ameliorating factor in 85% of the study patients advocates the higher prevalence of the milder phenotypes in our local population. Hence, it was concluded that significant number of the transfusion-dependent thalassemia patients of district Peshawar carry coexisting genetic ameliorating factors. Identifying these ameliorating factors will help the clinician to have a better understanding of the disease severity, and this will also guide him in devising appropriate management plan for these patients. Thank you.
Thank you, Dr. Gulrak Sohail. The third position was awarded to Dr. Noor Shamim. She is resident of Clinical Hematology and Armed Forces Bone Marrow Transplant Center. And her topic of her study was outcome of autologous stem cell transplantation.
Armed Forces Bone Marrow Transplant Center, and today the topic of my study is outcome of autologous stem cell transplant in patients with lymphoma. First, we will be discussing the 2016 WHO classification of mature lymphoid, histiocytic, and dendritic neoplasms, which are broadly classified into 5 major groups: mature B-cell neoplasms, mature T and NK neoplasms, Hodgkin's lymphoma, post-transplant lymphoproliferative disorders, histiocytic and dendritic cell neoplasms. Autostem cell transplants is usually done in patients with refractory relapse Hodgkin lymphoma and DLBCL, in cases of relapse Burkitt lymphoma, and as first line in mantle cell lymphoma and anaplastic large cell lymphoma. The objective of the presentation and the study is to determine the outcome of autostem cell transplant in patients with lymphoma. The study design was cross-sectional observational study, which was conducted in Armed Forces Bone Marrow Transplant Center. The duration of the study was from January 2010 to April 2020. The study population consisted of 23 registered cases. The inclusion criteria included all patients who were newly diagnosed, relapsed, refractory of both genders undergoing autostem cell transplant for lymphoma. The data collected included age, gender of the patients, baseline counts and chemistry, type of lymphoma, comorbidities, type of induction therapy given, and response to therapy. Coming to the results, amongst 23 patients, 83% were males and 17% were females, and the median age was 39 years. 70% of the patients included non-Hodgkin's lymphoma and 30% included Hodgkin's lymphoma. The number of cases included 7 cases of Hodgkin's lymphoma, 7 of diffuse large B-cell lymphoma, 3 cases of mantle cell lymphoma, 2 cases of anaplastic large cell lymphoma, 2 cases of Burkitt's lymphoma, 1 case of T-cell large B-cell lymphoma, and 1 case of small lymphocytic lymphoma. The pre-transplant disease assessment included 5 patients in CR1 and 18 patients in CR2. The mobilization protocol was given in 95%, it was cyclophosphamide and GCSF, and in 5% of the patients, it was G-Plerixafor. In 95% of the patients, the conditioning regime given was BEAM, and in 5%, it was Benda plus AIM. The median CD34 dose was 3.87, and the median TNC dose was 3.5. Neutrophil engraftment occurred at a median of 11 days, and platelet engraftment occurred at a median of 20 days. Complications post-transplant included febrile neutropenia in 78% of the patients, mucositis in 56% of the patients, gut toxicity in 52% of the patients, renal impairment in 26%, and respiratory tract infections in 39%. Conclusion is at a median of follow-up of 37 months, the overall survival was 91%, the disease-free survival was 76%, and the treatment-related mortality was 8%. In 23 patients, 2 of the patients expired due to treatment-related complications, and 5 of the patients relapsed. According to international data, in year 2015, a study was conducted that included 122 patients, and their overall survival was 50% with a median follow-up of 2.5 years. Another study conducted in the year 2011 included 157 patients, and their overall survival was 84% with a median follow-up of 2 years. Thank you very much.
And I'll be talking about telomere length measurement protocols, their advantages, disadvantages, and the importance of measuring and knowing telomere length of different individuals at specific time intervals. As we all know, that telomeres are nucleoprotein structures that consist of a repetitive unit of TTA-GGG and are located at the ends of the chromosomes. The foremost important function of telomere is maintaining chromosomal stability, as it prevents the chromosome from being identified as damaged and therefore stops their degradation and end-to-end fusion. In all normal somatic cells, telomere length decreases with each cell division, which has to be stopped from extreme shortening to maintain the normal functioning of cells. This balance is kept by a riboenzyme known as telomerase, but this can be done up to a certain level. Still, the telomere shortens due to the incomplete replication of lagging strand, the phenomenon known as end replication problem. The telomere shortening has detrimental effects, and some of the reasons of these shortening can be as follows. As we have seen previously in the slide, that telomere contains high guanine content, which makes it highly susceptible to the oxidation of oxidative stress. This causes damage which is not easily repairable and may result in telomere dysfunction. Secondly, hydroxyl radical attacks result in the accumulation of single-stranded breaks that lead to accelerated telomere shortening or even complete loss in some cases. Metabolism, radiations, carcinogens, compounds, and other exogenous sources may create ROS. There are reactive oxygen species which have irreparable DNA lesions. They can be mutagenic and cytotoxic and cause genetic instability, cell proliferation problems, and even cell death. One important point worth mentioning here is that living organisms do possess DNA repair mechanisms to repair DNA damage, but telomeric DNA is less capable of this repair, resulting in accelerated telomere attrition during cell cycle and replicative senescence. Telomeres seem to be very sensitive for both single-stranded breaks and double-stranded breaks. Here's a pictorial representation of all the factors that we just explained. Now we have to see the effects of abnormal telomere length on the life of cell and human beings. Critical short telomere induce cellular senescence or even the definitive inability of cells to divide. Telomere attrition in stem cells result in the depletion of their tissues and self-renewability. In both cases, telomere shortening can lead to different age-related pathologies. A wide range of studies have shown that dysfunctional telomere length in biological human sample is usually related to increased risk of degenerative diseases of aging. Diabetes, cardiovascular diseases, dementia, cognitive impairment, and even cancers. Telomeres are also related to several other human diseases in which some mutations of TERK are reported, such as dyskeratosis congenita, several hereditary symptoms of bone marrow failure, and idiopathic pulmonary fibrosis. Shortened telomeres are also seen in patients of aplastic anemia. And some studies even suggest that baseline telomere length is associated with late events of hematological relapse in aplastic anemia patients treated with immunosuppressant therapies. Thus, understanding the benefits and drawbacks of telomere length measurement is very important. Because short telomeres, meaning anything under the average TL, limits long-term stem cell division essential for tissue renewal. So we need to learn and apply robust and reproducible TL measurement methods that may predict onset of certain genetic or age-related pathologies. The first protocol that we are about to study is STELLA, which stands for Single Telomere Length Analysis, and it is based on ligation method, targeting the amplification of telomeric DNA from single chromosomal end through the use of primers that are specific to the subtelomeric sequence of that chromosome. But as this already suggests the difficulty of the situation, that is, the subtelomeric regions of the chromosomes are quite complex and lack specificity. Thus, primer designing for each and all chromosomes is not possible. The merits of STELLA include that it allows detection of critically short telomeres, no specialized equipment is needed, and does not require viable cell. The demerits include that it provides information for a small subset of chromosomes, does not provide mean telomere data, and cannot detect long telomeres, and is labor intensive. The second method that we are about to study is Qpcr method. In this method, PCR amplification of DNA sequence of interest is done using specifically telomere sequence design primers, with which fluorophore or a probe is attached. After each cycle, the amount of emitted fluorescence is measured, allowing the quantity of the starting material to be inferred. Point of mention is that a single copy gene is also amplified alongside during this protocol to compare the amount of telomere. For analysis, the telomere and single copy gene ratio is calculated to give telomere length. The following merits make this method the most commonly used one to measure telomere length across the globe. It allows detection in a very small amount of DNA. It is low cost, less labor intensive, and thus most commonly used method. The demerits are that it has high intra and inter-sample variability. The primer design can cross-link, giving rise to extra results, and different PCR mixes show different results. Southern blotting is a modified version of telomere restriction fragment method, TRF method, that was the original technique developed to measure telomere length. Therefore, it was also called as gold standard. In this protocol, DNA is exhaustively digested with cocktail of cutting restriction enzymes. These enzymes do not have any recognition sites within the telomeric or subtelomeric region. Thus, the telomeric DNA is not cut and remains intact. Telomeres from all the chromosomes are then resolved based on the size or the subtelomeric and telomeric region, and by Southern blotting with a probe specific to the telomeric DNA. Advantages and disadvantages of this include that it requires a high amount of DNA and it is quite labor intensive. Simplicity and low price reagents are the merits of this method. The uncontested champion among all the methods remain FISH, which stands for fluorescence in situ hybridization. This is a molecular cytogenetic method that can be employed to obtain information from metaphase or interphase cells. This method is based on hybridization of telomeric DNA of fixed cell with a fluorescently labeled probe with sequence complementary to the repeated unit of the telomeric DNA. The probe is labeled with a dye which upon excitation emits fluorescent signals. The demerits of FISH include that it requires a designated specialized equipment, extensive training, requires fresh blood, and the merits include high resolution and can detect length in limited number of cells. Another technique that is being used nowadays is whole genome sequence-based technique. WGS-based telomere length measurement supplies reliable sequence reads from telomeres. However, their standard alignment to the reference sequence provide limited information on the region of origin due to the repetitive nature of telomeric regions. The chief challenge for using next-generation sequence to measure telomere length is the need for bioinformatics expertise and softwares to decipher massive datasets. Important factors that should be considered when comparing WGS-based telomere measurement techniques are tool accessibility, ease of tool use, the time required to analyze one sample, and multi-threading ability. Now, there are some suggestions based on literature reported that can be used to maintain the telomere length. A proper diet, providing a proper intake of antioxidants and reduction of inflammation levels. Iron is very important trace element for maintaining a metabolic homeostasis and genome stability. Nevertheless, it is required in a very relatively narrow range. Otherwise, iron becomes a high potential generator of ROS. High levels of plasma vitamin D are associated with long telomeres. Folate is important, and lifetime practices of exercise might help slow. In 2016, I performed sudden blotting on aplastic anemia patients from AFBMTC. This test was done at National Institute of Health, USA. This table shows that telomere length was measured in 10 patients with TERT and TERK mutations. The highlighted patients are the ones that have low telomere length as compared to the average ones. The telomere length of these patients was again compared to their ages, and it is represented in this graph. This article was published from this work, and it can be studied to understand the results in detail. Nowadays, we have established telomere length measurement protocol for research purposes at AFBMTC through Qpcr method using Costeffective methodology. We are comparing telomere length of aplastic anemia patients with age-matched healthy control samples. Our initial data is quite promising, and we intend to extend this facility for inherited bone marrow failure syndromes and other telomeropathies. Now, there is a prayer from me to you. Live longer, telomerically speaking. Thank you.
Xia Jun, and her topic was complications associated with central venous catheterization.
I am Major Najia, bone marrow transplant nurse in Armed Forces Bone Marrow Transplant Center. Today the topic given to me is the care of the central venous catheterization in the patients undergoing chemotherapy and stem cell transplantation. So the central venous axis is the backbone of the bone marrow transplantation and chemotherapeutic protocol. It has direct bearing on the success and the favorable outcomes of these specialized treatments and modalities. Despite of being the safe procedure, still the placement of the central line is associated with number of complications. Now the central line is indicated for the chemotherapeutic and conditioning protocols, long-term intravenous antibiotics and other medications, for the frequent blood draws, for apheresis, for the monitoring of the central venous pressures, and for the long-term parenteral nutritions in the end dialysis. These are some catheters. This is the Hickman catheter. These are the central venous catheters, single lumen, double lumen, and the triple lumens. It's a PIC catheter. Now, which central vein is to be cannulated? Mostly subclavian veins and intrajugular veins are used for the central lines and very few for the femoral veins. It's an internal jugular vein. And in this picture, we see now the complications associated with central lines are very dreadful. It might be infections, hemorrhage, malpositioning, in sometimes blockage, air embolism, leakage, line breakage, and sometimes pneumothorax. This X-ray shows the malpositioning of the central line, and this X-ray shows the hemothorax. The objectives of my study is to determine the safety of the central lines and the complications associated with their use in the patients undergoing chemotherapy and the bone marrow transplant for various hematological disorders at the Armed Forces Bone Marrow Transplant Center. Total 1,000 patients who had the central line placement for the different indications were included in this study. All the observations were written in the specifically designed performance. In 312 patients, central lines were placed for the bone marrow transplant, while in 441 for the chemotherapy. For 190 patients were passed central line for the venous accesses, followed by 4621 for ATG and apheresis. Similarly, in 808 patients, central line was placed in the right side, while in 192 for the left side. 706 patients have the subclavian central venous catheter, while 96 have internal jugular vein, and none of them for the femoral vein. This pie chart shows the disease distributions. About 135 patients of AML have the central lines, while 100 patients of ALL have central lines, 116 for aplastic anemia, 63 for beta thalassemia, 28 for CML, and 59 for the other diseases. This biograph shows that 773 patients have the central lines, while 29 were Hickman, 2 were Pick, and 1 for Potakath. This biograph shows the mean line days, 36 days for the Hickman and 29 for the central line. So 61 patients have the central lines in the local anesthesia, while 321 were given the general anesthesia. 652 central line were passed in 1 attempt, while 226 were passed in 2 attempts, followed by 5827 in 3 and 4 attempts. 211 patients have the complications of systemic infections, while 62 central lines were diagnosed for the positional flow, 23 for catheter colonization, while 32 for the leakage, 46 for the blockage, 21 for bleeding, 13 have the accidental removal, while 5 have malpositions, and 3 have the pneumothorax. In 113 patients, the blood cultures were positive, while in 29 patients, the CV line tip cultures were positive, while in 22 for the CV line fluid cultures were positive. And the 49 cultures were positive for the Staph aureus, while 24 for Pseudomonas, 14 for Klebsiella, and 22 for E. coli. The reason for the removals, 628 patients, in 628 patients, central lines were removed at the time of discharge or in some cases for death, while in 28 they were removed for blockage and 45 for proven line infection. The accidental removal were in 16 patients, while 178 lines were removed for suspected line infections and 87 for other things. The conclusions of my talk is the placement of the central venous catheter is the safe procedure and can be managed in the transplant and intensive care facilities with acceptable rate of the complications that were provided by staff in adequately trained and safe CV line handling. This is the take-home message. We can take care of the central venous catheter by using the aseptic techniques. If we did a hand hygiene, hand washing, we wear the gloves, we should do the frequent stopper change, proper heparin flushes, monitor the signs of local induration or infections, avoid the local ointments, and remove the line when no longer line is required. I end my presentation with these words. Ho ilm ki daulat to tahaffuz hai yaqini. No doubt the diseases are treated by the order of Almighty Allah, but by the grace of the God, the safety of the patient lies in our hands. Thank you so much.
Ladies and gentlemen, because we are running short of time, all these presentation talks, they are available on the PSH website, and they will be available for 2 weeks, and after that they will be available on YouTube. So in the end, I would like to congratulate all the speakers. They have done their hard work, and it's all because of their efforts and all their hard work. Congratulations to all of you. And in the end, I would like to thank organizing committee HAEMCON 2021, chairperson organizing committee HAEMCON 2021, Professor Dr. Brigadier Retired Nuzhat Mushahid, for all her efforts, and President Pakistan Society of Haematology, Professor Dr. Major General Parvez Ahmed. And I would also like to thank all my panel experts, Professor Dr. Nadeem Ikram, Professor Dr. Lubna Zafar, and Professor Dr. Aisha Junaid as well. And now I would like to hand it over to Madam Nuzhat for her closing remarks. Ma'am, over to you, please.
Bismillah ar-Rahman ar-Rahim. Dear colleagues, worthy participants, members PSH, honorable national and international guest speakers and sponsors, Assalamu alaikum and a very good evening. I stand here to fulfill my final former duty of declaring closing of HAEMCON 2021 virtual conference. Let me recite a translation of verse which says, O Allah, owner of sovereignty, you give sovereignty to whom you will, and you take sovereignty away from whom you will. In your hand is whom you will, and you humble whom you will. In your hand is all the good. I am extremely humbled and eternally grateful to Allah Almighty for bringing the honor of organizing, managing, hosting, and now closing this 3 days event. Alhamdulillah, this occasion has made a history, leaving a feeling of satisfaction for having the honor of this legacy. All the success of the event are unto Allah, and then to my team, and all the shortfalls are unto me. No feat of any standing can be achieved alone, and neither did I. I thank President PSH General Parvez Ahmed for his trust, support, and believing in me. He gave me free hand to plan and conduct proceedings. He was instrumental in setting up the team whom I led. I acknowledge and thank Dr. Shehzad Nasir, the Secretary HAEMCON 2021, for his moral support and assistance. Dr. Sabah is an example of their support provided to me. I don't know how possibly I could have made all the calls that she has been doing and being the workhorse at NUMS. Thank you, Sabah. My very special love and gratefulness for my better half, Professor Mushahid, who is most important pillar of strength in whatever work of substance I have ever done. This HAEMCON would not have been possible at all without the remarkable talent, skill, stamina, and hard work of Mr. Imran Waheed. Imran, I will always be indebted to you. I must acknowledge the event management grace and its executive, Mr. Masood, for making everything happen the way it did. He was resourceful, thorough, thoughtful, competent, and delivered on whatever I demanded on click or a call. The institutional support was remarkable, and foremost is that extended by NUMS under dynamic leadership of General Salim Ahmed. We are grateful for his generosity and embracing our needs with open heart. Dr. Nisar, Dr. Saima Farhan, along with her team, made us manage the participants of Children's Hospital Lahore, and we are thankful forever. Dr. Sabah Jamal nominated Dr. Fatma Miraj and her team to facilitate us, and the team facilitated us greatly in establishing Karachi studio and blood center premises in spite of their other pressing commitments. We cannot forget her support, attention, and generous offers that made us feel part of Indus team. The most significant role in arranging parallel session for nurses and paramedics was played by Dr. Natasha from Aga Khan University Hospital. I am extremely impressed and can't thank her enough for being ever ready to help. Her responsiveness, thoroughness, and management in most befitting manner. Knowing that she is the secretary-elect bodes extremely well for PSH. I am grateful and obliged to Brigadier Kamrun Nisar Chaudhry, Commandant AFBMTC, who was instrumental in arranging second day session. She spared their staff and doctors and nurses to participate and organize as well as moderate. The success of program is gauged primarily by the scientific content, and for that we are extremely grateful and thankful to all the international and national speakers to respond to our request, accommodate us even at oddest of time to deliver live talks. The joy and satisfaction of scientific sessions could not have been complete without all the panelists sacrificing their precious times to be with us and adding value to the knowledge brought by the speakers. I am indebted to all moderators who conducted the sessions flawlessly and with full command on proceedings and responded to my communication with courtesy and zeal. They won everyone's praise. Kudos to the jury of free papers and e-posters for their time, efforts, commitment, and timely evaluation and result announcement. They made it look simple, but we know they were given difficult tasks, and we are grateful and will remember them forever. My very special thanks to Dr. Ghassan Umair to evaluate papers submitted and prove to be the real support in organizing and lining them up and advising me on it. The sponsors and supporters of this event from industry need special acknowledgement, gratitude, and thanks to provide us with all the magical resources that made it possible what you saw. In the end, I must say that any performance is only worthwhile if the audience sees it and appreciates it in any capacity from anywhere and made us believe that the efforts are worthwhile. Thank you, everyone. Jazakallah khair and Khuda Hafiz.